So this is the second part of the introductory lecture. And here we're going to talk about a lot of issues related to research. And addiction services research can be understood and studied at three different levels. The most common one is the clinical level, which represents the interaction between a client or a patient on the one hand and a clinical health service provider on the other. This is the typical doctor-patient relationship where a patient comes for a particular service. The second level is at the program level, and programs have been designed that specialize in addiction services, and they're somewhat different than other medical and psychiatric services because they're usually run by people who are very knowledgeable about addiction, and they are organized in ways that maximize the impact. A third level that we're going to be talking about in this course is the system level. One fundamental question is, to what extent do all of the clinical services and the programs add up at the population level or at the community level or at a national level? At the system level, is the collection of services having an impact? And the reason this is important is because often money is appropriated by policymakers to deal with an epidemic or with a particular type of substance-related problem that is designed to drive down the population rates. And a good question is, can treatment have an effect at the population level? Research methods can allow us to understand a variety of important questions that society wants answers to, that policymakers demand of people who receive funding for services, and at the level of patients and families, they want to know from a consumer's perspective what works and what doesn't. And that is the ultimate purpose of research. So addiction research methods allow us to understand the efficacy and the effectiveness of individual services. Efficacy means under research circumstances, when you provide an optimal dose of an intervention, does it work? Effectiveness applies to how it works in the real world, which may not be optimal. Other questions and things that research methods are designed to provide us with is an understanding of the performance of the entire service delivery system. So to what extent is the collection of services having an impact on hundreds, if not thousands, of people with substance use disorders? Thirdly, the collection of data using sound research methods can help us to understand the characteristics of the clients or the patients who are using those services. Research also helps us to understand the needs of a population. How many people are in the general population or in a community that needs services? And it helps us to estimate what the demand is. Even if you have a service, people may not use it. And finally, research methods at a systems level especially can help us to understand whether the services are equitable or they're just designed for one part of the population, whether they're efficient in terms of providing the best use of resources, and certainly we want to know if services are economical. All of these things are important, and they can be evaluated by sound research methods. There are boundaries to addiction services, and in our course we're not going to talk about primary prevention. That will be left for a policy course in this series. We will talk about secondary prevention or early intervention, services that are delivered within the general healthcare system. And we'll talk most about what is called tertiary prevention, which is not what we do with patients or people at risk, but what we do when somebody has developed a clinical syndrome like dependence where they need treatment. And sociologists have analyzed the way that societies set up addiction services. And they have suggested that there are three basic reasons that define the boundaries of addiction services. The first and most obvious one is the care of people who are dysfunctional, who are distressed, and who are incapable of functioning normally in society. And care is a humanitarian goal which is more than enough to justify the use of treatment services. A lot of treatment within medicine and psychiatry is designed to cure people. And with addiction, it becomes a little bit more difficult because when somebody develops an addiction, sometimes we can teach them how to become abstinent and get on with their lives, but we may not be able to cure the neurobiological changes that have taken place, which increase the risk of relapse. So cure may be an elusive goal for addiction treatment. Another goal for treatment, particularly for drug abuse, but also for drinking and driving, is to control people's behavior that has become a threat to other people in society. So treatment serves a variety of different functions. It's not just caring for people, it's not just curing people, it's also controlling people who have lost control over their behavior. To give you a quick history of the types of questions that we'll be asking you to ask yourselves during this course, let's go back just about 50 years. 50 years ago, we didn't know much about how alcohol treatment worked. We didn't even know whether it was effective. And so the main question at that time is, compared to no treatment, is treatment effective? In the 1980s, we started asking questions about whether one type of treatment could be found that's more effective than other types of treatment. And during this course, we're going to be talking about a lot of different types of treatment, ranging from AA-based 12-step programs to psychologically based psychotherapy programs to pharmacological interventions. And what we want to know, and what people started asking in the 1980s, is one type of treatment more effective than another? In the 1990s, we started trying to figure out whether therapeutic mechanisms that could be identified were responsible for behavior changes in different types of therapy. So if you have a pharmacotherapy, a drug that operates on a neurotransmitter in the brain, then we need to do brain imaging studies to find out what the mechanism is, to prove that by providing a drug as opposed to a placebo, that you're somehow altering the brain chemistry that is reducing craving and preventing relapse. Recently, we started trying to figure out how we could expand the base of treatment to get it out of treatment programs that are just specialized for people with substance use disorders and get it out into the community, get it into doctors' offices, get it into the emergency department of a hospital, and try to begin identifying people earlier and intervening with people at risk before they develop a serious problem. And finally, what we're now trying to understand is how can we improve the entire functioning of this spectrum of treatment services, ranging from early identification to outpatient treatment to residential treatment to detoxification. When you put it all together, can we design systems that serve the needs of a community and a population? In order to do this, we're going to be looking at different types of evidence. And the scientific method provides us with tools, not just for randomized clinical trials, which is considered the gold standard, but many other ways of collecting information about how treatment works and for whom. Descriptive epidemiology is based on surveys in the general population, asking people questions. We can use quasi-experimental and correlational studies to look at the correlates of recovery from treatment. We can do natural experiments where a country, for example, like Iran or China, invests massive amounts of money and resources to control an opioid epidemic. We'll be talking about qualitative research, gathering information more informally from people who run services, and health services research, the functioning of a program to find out how many people it serves, how many people become abstinent, and how many people need 3 or 4 treatments in order to achieve complete recovery. Finally, health systems research is another area where we're beginning to develop methods for planning, monitoring, and evaluating services. And putting all this together, we have to put it into historical context. What is an evidence-supported intervention? Taking all of these different research methods, this entire toolkit of different ways of investigating treatment, what is the criterion that a government policymaker, a public health department, a hospital would use to judge whether a particular intervention is evidence supported? This definition, which is in one of your readings by Kathy Carroll and Bruce Rounsaville, is a rather narrow definition. It's based on what is typically used to show that a drug is able to be put on the market and marketed to deal with a particular disease or infection. Usually it requires 2 randomized clinical trials. Again, that's considered the gold standard. You need to have a study that has appropriate inclusion criteria. So you can't give the drug to everybody. You need to carefully define whether the people actually have the disorder, in this case, alcohol or drug dependence, and if they do, you need to have a sufficient number to do statistical tests to detect a difference between a control group and an experimental group. You also need to have fidelity to the intervention. If it's a drug study, people have to take the drug in order for you to demonstrate the drug is effective. If it's a talk therapy, like a psychotherapy, it needs to be guided by a manual. And finally, you have to have appropriate outcome measures. We're going to be talking about all of these criteria for an evidence-supported intervention in the coming lectures.